Hi, I'm Dr. Raj Aquila. I'm UK Ambassador and Global Key Opinion Leader in Facial Medical Aesthetics. Welcome to my series of online training webinars. So in terms of consultation, so with Kim, age 39, she's had previous treatments before. So normally what I'm doing is I identify the top 3 priorities for the patient. So Kim, you already mentioned, you said number 1 is the eyes, okay? Number 2 is the marionettes, and number 3, I think you said crow's feet, yeah? Is there other things as well that we can add to the list in that same kind of hierarchy, so we prioritize them?
Here.
4 headlines.
4 headlines.
Yeah. Anything else?
No.
No? Okay, cool. So the other thing when I do consultation is I told you there earlier about focus on emotion and health. I think it's a really important aspect of aesthetic which we don't even major in, because we're always so dialed into beauty and optimizing aesthetic, but she'll be very bothered about it. So just yes or no. Is it interesting to you to look less tired?
Yes.
Right. What about if you were to look less sad or more happy?
More happy.
Okay. Less angry?
Yes.
Okay. What about less sagging?
Less sagging?
Yeah?
Definitely.
Okay. Do you think you're saggy?
Slightly.
Okay. Where is the sagging?
Here?
Yeah, sure. And so I'm just going to get to the point in terms of how does that relate to anatomy and also strategy. Stuff like to look more feminine.
Yeah.
Okay. More attractive. To look younger.
Yeah.
Okay. And what about to change your face shape, to make the face look slimmer?
Yeah.
All right, cool. So all of those, I've taken things which are degrading. That's just codes, isn't it? With the visionary stuff we were doing last year. If she looks sad, okay, it's going to come from negative brow axis, negative canthal axis. It will be potentiated by tear trough. Also, don't forget mid-cheek groove is also an oblique negative axis. The nasolabial fold, the sad corner of the mouth and the oral commissure. And then also, as we age and the mentalis starts to rotate, we get this little upturned crease here, labiomental crease. So there's potentially 1, 2, 3, 4, 5, 6, 7 different symptoms, if you like, that translate towards perception of sadness. We look at tiredness. Remember I mentioned already, tiredness can be perceived by where you have sagging, prolapse, or if you have excess. Okay. So we normally tend to prolapse here. So this superior lateral quadrant of the upper eyelid, also the malar mound. Okay. The infraorbital fat, and she has got that, hasn't she? She's got a bit of eye bag going on. Nasolabial fat compartment excess, so like this little sausage. Buccal fat excess. And finally, when you do age and you have this jowl fat excess there. So let's just focus on those 2 for the time being. If you want to influence those things and you want to make them look better, what is the output for each of those points? It means what would be the solution? Lateral eyebrow and the lateral upper eyelid. Okay. Also the lateral canthus is influenced by temple. Agree? Lateral canthus and lateral lid cheek junction and the malar mound and the mid-cheek groove all influenced by the zygomatic arch. Okay. Mid-cheek groove, sausage, nasolabial fold have an impact from zygomatic eminence. Eye bag, tear trough, influenced by SOOF, or basically just inferior to orbicularis retaining ligament. Look to the ceiling, darling. Good. You see how she has elevation, depression, elevation, right? The presence of the depression there, so the insertion of orbicularis retaining ligament, so the tethering down, exacerbates the fullness that you perceive from the eye bag and the malar mound. So you gotta inject there to be able to bridge the gap. The other thing is, when you inject here and you have the vertical support of the lateral canthal ligament, you do an injection canthopexy, and that makes her eye look more happy. Yeah. Okay, nasolabial fold with the heavy sausage behind it. You inject medial to there to mitigate it. Heaviness, and absence of volume. So what we want to do here is build a vertical channel from the pregial sulcus, which is here, and we go up, and we go up. Now, if we want to deal with this channel here, because don't forget, guys, there's a vertical deficiency, but don't neglect this. There's a transverse deficiency or an oblique deficiency as well. It's typically corresponding to the upper margin of the mentalis muscle. So if we connect here to here, you'll get a complete chin and jaw union. So here and to here, okay? If you want to take the weight off that, yeah? This, you're asking me about buccal reduction. The strategy for it's actually nice to draw it on because we can see which is the most impactful. Look, zygoma has some effect, okay? Look, subzygoma has a profound effect in that area. So there we go. Subzygomatic restructuring. And finally, look here. You see, angular mandible also has some effect. Now, when you combine the three of them together, it's enough at her age, 39, to just thin out that buccal compartment. If she has excess here, and we're pulling back, and then we're blending anterior to that, we're actually camouflaging the problem. So let's put in angular mandible right there. Okay, good. Now then, that's just that emotive part. I start with that with Peg. See, I don't know, we're mates obviously, but what I was saying there about the sadness, tiredness, and the looking slimmer in the face and more feminine, is that of interest to you?
Yeah.
Yeah. So she's already, even if she's a proper patient, in clinic, she would be captivated by that. And so in terms of the consultation, the assessment, and making the plan together like that, they're much more engaged. Now we can get into the other stuff about geometry and art and beauty and stuff. Okay, 1/3, 1/3, 1/3. So which is the longest, which is the shortest third? Or are they equal? Good. The reason for the shortness here, though, you can see it really clearly, is when I do that, you can see a clearly demarcated upper limit of mentalis. So we know that that muscle's contracting. Even if it doesn't look like it's hyperactive, you can see that crease. So shortest here. Where's the longest, do you reckon? I think in this measurement she's long, through here. But because she's got high brow, that distance is short. So if you're gonna try and shorten here, you want to try and not necessarily give her too much there. You probably bring the elevation into the middle third like this. That's how you balance the vertical corridors when you're doing your Botox. Okay, so if we're gonna elongate the lower third, what's the strategy for that? Labiomental crease, apex of the chin. Also, if you increase the height there, what's going to happen? If you inject there, and there, corner of the mouth goes up, right? If you lift the corner of the mouth, you increase the perceived height between the jawline and the mouth. Make the lower third look longer, right? It's an illusion, but it's a really useful one. So elongating here, shortening this one. And then for the middle third, well, we've already identified where she has light and shade and where there's a potential for giving better harmony between the compartments. But if we look at specific structures within these thirds, do you think the lip is well balanced when compared to the lower third of the face? If we look at the relationship of the strength of the nose, the strength of the lips, and the strength of the chin. I'll ask you another question. Do you think she's 1/3, 2/3? She good?
Yeah.
Okay, now let's go here. Do you think she's 1/3, 2/3? No. Sit forward. She's deficient in the upper. Don't just look at the AP. Patients don't appreciate, close the mouth. Patients don't appreciate the lateral as much. So I look at the rickets line, and what I'd like to see with the rickets line is lower lip 2 millimeters behind the pencil and upper 4 millimeters behind. You can see here that the lower lip is virtually touching the lip and the upper lip is about 2 millimeters. So what we've got here is a potential for chin projection like this, to bring her chin forward. So not just inferior extension, it's anterior projection as well at the pagonian. So the additional points would be pagonian and apex. Okay. So Kimmy, just turn this way. Just say your name and your address.
Kim.
No more.
Kim Thompson.
That's enough.
Yeah,
So don't forget in these patients to stick 3 units of Botox here at the nasal spine. Okay.
Oh, God.
Sorry. No, I won't do it. I'm just maybe for the guys. Would you like your nose to be straighter today? Right. Okay. So we will go here and we'll go here, but we ain't going to stick a needle there because we're going to do cannula all the way up. Okay. The width of the chin, it should be the same width as her nose. It should be the same width as her intercanthus, and it should be the same as the width of her eye. Keep looking in the camera, darling. Lateral canthus to the edge of the face when viewed in AP, straight down the camera. So what do we see? I mean, you're the assessors. What do you think? Chin width, first of all, is it the same as the intercanthal distance? Bit wide? Bit wide, so we've already hit this point to make it narrower, okay? What about the width of the nose in relation to the intercanthus? Wider, excellent. So we've already put this in to make her pinched, injecting at the piriform. What about the width of her eye when compared to the intercanthus? Look straight into the camera, that's it. I'll ask you another question. What do you think the canthal axis represents? If it should be 12 to 14 degrees of upward tilt, do you think she's got it? No. In fact, worse than that, come this way, she has a active negative vector here. She has a definite downward tilt. Therefore, the strategy for that is, and we showed here, is going to be 1, 2, 3, 4. What about the lateral fifth of the face? When you look at it in comparison to intercanthus and width of the eye. So this would be the distance between here and the hair when you look at it in AP. Smaller, excellent. Now, here we go. Is she narrow here? So the lateral fifth is comprised of projection, 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 projection. What we want to try and identify is where is the need for the maximum projection. So is it there? Yes. Is it here? Okay. Is it here? No. Is it here? No. The reason why I'm asking you that is what's the product selection and what's the depth? Requirement, requirement, voluma, voluma, bone, bone, right? Volift, volift, sub-Q bone, all right? Cool. We also, when we were doing the upper third, in terms of the elevation and the shortening of the third, we didn't look at the light reflex here. Can you see? Look how she has a projection, depression, projection, right? So she has a prominent supraorbital bossing. And if you look like this, you can see that she just has a cavity right there. Okay, so that's the last one. Right, now here's the where we break it down. That's how I sell now to the patient. So she's like got only 50 quid in her pocket, right? So she can't even afford like one syringe. So I'm just now identifying so many different things, but I explain all of that to her, yeah? And I say, well, look, here's the situation. First of all, how would you mark yourself out of 10 now?
10.
No, you don't. Yeah, she does. She actually does.
6.
6, right. So, no, but what about like if you got a really nice new dress and, you're going out, what would it be? 7, yeah, okay. So let's give her the real score. For each of the indications, yeah, symptoms, points if you like, we're going to give her a score of minus 0.1, okay? From 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, that's actually 1. 12, 13, 14, 15, 16, and this is actually 17, okay? The real score is 8.3. And that's pretty damn good for someone at 39, right? So, okay, immediately now we've got a better relationship because I explained that to her and how we're gonna, how we're gonna work it out for her. But now we've got to make a plan, right? So she's told me about 3 things. Number 1, number 2, and number 3. I'm actually taking out a lot of those things just with this plan anyway. Okay, so take them out of the equation, and then we look at how we're going to structure the treatment for her moving forward. So of course, Botox is pretty easy. I say to her, listen, Kim, we will start off with structural work, okay, and we'll do your foundation building, and then we're going to build up from the base until you get your results at the surface. We'll use Voluma in these points on the bone. Good. And then, after you've done these points, you're going to come back to me. So it's like 1 or 2 syringes, depends on her budget, right? Then you're going to come back to me and we're going to do Volift, right? So we're going to use something a little lighter. We're going to do that in all the areas where you have dynamic, so you have movement, and we need to have a good resulting expression. So we do also here and here, here, here. Why do I use Volift here, you see? Because it's mobile. See how my fixed points are structural, and so I use the Voluma. The only reason I'm not using Voluma here, by the way, is because she's already projected, so I don't want projection with that. Yeah. With the other thing with the Voluma, if you're going to do nasal spine, you can put Voluma there. The columella branch of the superior labial artery is a redundant vessel, correct? Yeah. You tie it off in open columella rhinoplasty, so don't even worry about vascular risk here. Even if you were to inject it, it's okay. It has a lot of collateral in the septum. Volift. Volift. Right, now, then we say, but then come back at the end of it and do a textural session, fine-tune using Volbella or whatever you want to use in your office. And for that, then we'll use it here, okay? Now, because I'm only doing Volbella in such limited places, there's a really great opportunity there for me to use the rest of that syringe to optimize all of the rest of the results and complete, yeah? And this is this underselling, under-promising, over-delivering effect, right? So, supratrochlear, supraorbital, and look here, 2 centimeters above the superior orbital rim is there, like this. So that injection is on the bone, below the danger. You've got to make sure you crunch through that galea. When you're doing the temple, the temporal fusion line, so the frontotemporal suture is there. Orbital crest, right there. And then you have the upper margin of the zygomatic arch is here. The superficial temporal artery is running in the same level as superficial temporal fascia, so it's here in this lateral third of the fossa. And I can feel it now with my 2 fingers. To be honest, it doesn't really represent much risk unless you're injecting superficially. Some guys, like remember in Paris, Wolfie was talking about, this cannula to mitigate the risk. This is nonsense. For him to get down to the bone here in the temple, he would have to drill that cannula all the way through 2 different fascias, a big, thick temporalis muscle, and plant it on the periosteum. It's just, the patient will punch you for this. So I think you're best off taking the needle and going to the target. Superficial temporal artery. The posterior deep temporal artery is there. Okay, it goes 2/3 of the way up. It's running in the same level as temporalis muscle. And then you have the anterior deep temporal artery, which runs 1/3 of the way up, and it's running on the bone. What it means is that this quadrant here, this 1 centimeter square, is a safe quadrant when you go to the bone. And furthermore, then the product will start to hydrodissect underneath the fascia, and it will flow all the way down. So if you have a maximum point of concavity is there, you can fill it from the superior medial quadrant in a safe way. The muscle is thick here, right? It has an origin here. The muscle has an insertion on the temporal fusion line here, so it's thin. Means therefore the blood supply here is rich and the blood supply here is weak. This means it's dangerous and that is safe, right? It's really basic. So a lot of people have such a fear of temple, but actually when you look at it like that, it really justifies, you know, your strategy. Good. Cheekbone and subzygoma. Inferior border of the zygoma is here, and running in that you have got the transverse facial artery. So basically all I'm saying is, you know, don't go at the cheekbone this way because you might skewer it, and also don't mess around in this area with a needle as well, right? I did mention that little temporozygomatic foramen. If you've got delicate fingers, you can just feel it just here on the eminence. It just gives a tiny little neurovascular bundle, but it often corresponds to the malar mound anyway, so it's that you wouldn't inject on that upper eminence. Speaking of malar mound, you know, wherever I've marked out these areas where she has prolapse, excess or sagging, there are no-go areas. So you're not to place even a drop of product into those areas because they're already full, right? Okay, look to the ceiling, Kimmy. Inferior orbital rim. And I'm marking it as red because it's a no-go. If you put the needle past that, you breach the orbital septum. And 1 centimeter below the infraorbital rim, look, this is the midpupillary line, right? This is the medial limbic line, right? Medial pupil. So there's 2 millimeters difference here. So 1 centimeter below is there, okay? And that's her infraorbital foramen, which spits out in this direction. Do you see how that point is superolateral to the danger? And so every time when I do a gig, then someone will say, yeah, what about infraorbital foramen? And I'm like, well, okay, listen, just palpate it, or if you can't feel it, map it out so you know for sure where's your product and where is your foramen. The other little interesting thing here is, I said the infraorbital rim is a no-go, of course it is, but that doesn't mean to say that between the rim and the lid-cheek junction is a safe place to inject. That's infraorbital fat, so you would augment that and make the eye bag worse. So that's a definite no-go for me as well. Which is kind of why when I'm looking at cannula use here and you're doing all this stuff, yeah, I don't think it's appropriate because I think some of it's going in here. So for me, cannula in the tear trough is the last thing that I do. I start with a needle. Okay, interesting. This one here. Bite for me. So the premasseteric notch is right there, okay? And then the facial artery is coming like this, okay? It's like has a tortuous course. Then it starts to follow just lateral to that buccal maxillary retaining ligament and then goes up nasal wall. The facial artery will stay lateral to the ligament, okay? It's bound by the ligament. If you inject medial to the ligament, away from the ligament, you're safe. If you inject lateral to the ligament, you're in the same path as the artery. The artery is sitting on the LLS, means it's in the middle. So you've got skin, subcu fat, then you have artery and muscle, then you have bone. So you go to the bone and you're safe. If you're going to inject superficially, stay in the subcu to do a sandwich technique, okay? Combination of the two. Superior labial artery coming off like this, okay? Inferior labial artery coming a little bit lower, so 1 centimeter down and 5 millimeters up, right? Running underneath the orbicularis oris muscle. So when you're injecting 1, 2, 3, stay in the subcu, right? Otherwise, if you pierce that muscle, you're going to potentially have a problem. Mental foramen. 1 and 2, okay, and maybe even 3. When you're injecting those points, you are going to be on the bone, so make sure you're aspirating, okay? This is probably the safest point in the face. This is probably the safest point in the face. If I'm going to teach anyone to inject fillers, I will start with them too, okay? Where's the most dangerous? Right there, okay? And that's where they do start them in this day and age, especially in the UK, you know? It's unbelievable. right here. So we have the marginal mandibular branch of the facial artery that runs in the submandibular groove. As I said, you know, when you're injecting the predial sulcus, try not to access from here because you could skewer it on the way in. Take a lateral approach, okay, and inject medial to the mandibular retaining ligament. We've got relative safety here. However, I did mention this, didn't I? So sternocleidomastoid muscle, big pulse, and her external carotid is going like this. By the way, the external carotid goes behind the zygoma there, continues here as the superficial temporal artery. It gives rise to the transverse facial like this. Sorry, just a word of warning as well. Anything that you can enter, anything that can go back into this potentially is going to go to the brain, all right? So, you know, that's the stroke patient. When you're dealing with this area here, I showed you on the iPhone, you know, like the corner of it. This is her existing angle of mandible. So we're going to do one here, right? And then you can do another one on the posterior border. But if you miss this and go underneath it, or if you end up here or here, you've got a big vascular problem here. So always guard. Look, see, I guard the inferior border and I make sure the needle is going over the top of my finger when I'm injecting them. Same here. I'll guard that posterior border and make sure I'm at the back end of it. So what I'm going to show you is the landmarks, you know, so here we go, because I know we've got sterile now. So temporal fusion line, intersection of orbital crest, 1 centimetre up the line is here, 1 down into the fossa is right there, and then back to the orbital crest is here. So that's your square, okay, which is a safe square. And in that square, still have a little feel for a little branch of the superficial temporal, because it has an anastomosis with the supraorbital. She's good to go. So just go perpendicular, straight down. Well done, sweetheart. Do a 2-hand aspiration. So fix with your non-dominant hand and give it a good suck, okay, for at least 3 seconds. What was Wolfie going on about? 30 seconds. You don't have the time for that. So 3 is enough.
What gauge needle?
This comes with the volume, it's 27. But 27 ultra thin, so behaving like 29, yeah?
0.3 cc?
I will go up to 0.5 for the temple, because don't forget, whatever I'm doing here, this has to travel down. You'll see actually that there's no bump being formed, it's gradually migrating.
You're hitting the bone.
Yeah, I'm always on the bone. So this is hydrodissecting now underneath the deep temporal fascia. Right, the objective of doing this point is, let's just refresh, is lateral brow lifting, lateral upper eyelid lift, and lateral canthal lifting. Okay. So come out. Oh, wait, by the way, look, I come slowly. Some people say to me, well, why do you come back slow? Well, it's because if you come out fast, the blood follows you. But if you come out slowly and through the layers, they all seal up behind you. Yeah?
But you're not injecting as you're coming out?
No. I'll leave it and then come. Okay, so then now, the moulding. Mould laterally, okay, and mould inferiorly, okay? And this gives the final result. But you can see, look, it's flowed, it's moulded itself, yeah? But this Vycross is self-moulding. Let's have a look and see whether did she get brow lifting or did she have lifting here in the corner of the eye? I can't see, yeah? Is better?
Yeah.
Let's have a look. Let's come forward.
No, definitely not.
Yeah? Okay.
Mm-hmm.
Good, okay. So let's go back. So what we'll do now is we'll get to that, the zygomatic arch and hit that point just in front of the retaining ligament. How did that feel? You okay?
Mm-hmm.
Good. Perfect. Why is the skin here red? Because the cream, yeah?
Yeah.
Right. Thank you, darling. Okay, so what we're going to do here is we'll feel for the suture, your ligament, like this. Right here. This is the suture. If I pull that back, the origin of that ligament is there on the bone. The 2 dots are, that's the origin on the bone. That's the insertion into the skin. So if I push it forwards like this, I've closed the ligament. Now it's open, right? So if it's open and I inject just in front of that ligament, when I release, okay, the ligament is trapped on top of the voluma, okay? It's a very, very important concept for injection lifting. Very important. Cheers, God. Right, so look what I do here. I take that voluma and I squeeze it into the ligament. So what I'm doing here is, look, ligament's fallen, voluma's in front of it. I pushed it back and I'm squeezing it into the ligament, forcing it back, right? Don't forget that voluma, or anything like that you're using which has this high G prime, has a very high lifting capacity. So you can fix tissue in place, and that's going to be fixed there, you know, for 18 months like that, or 12 to 18 months. Yeah. Good, yeah. So what we should start to see is we have obviously contour and better, you know, femininity, attractiveness. But the other things that we should start to see is that the buccal compartment here should be slightly reduced now, okay? Because you have 2 vectors of lift, one this way and another one this way. Yeah. Okay. Thank you. Right. Where's the curvature here? So, in fact, she doesn't really have much curvature. She's not genetically that blessed on this eminence. So if that's the case, lateral eyebrow, upper alar tragus line. Or what you can do is, you can look and see where the mid-cheek is going, and the cutaneous insertion of the zygomatic retaining ligament, and inject medial to the ligament. Okay, to be able to force it back. So let's try and do that. She's got a malar mound here, and she has a slight depression of mid-cheek groove there. Look, there. So I will pull the ligament back, and then I'm going to inject just medial to the ligament down to the periosteum. Okay, and again, always mold lateral into the ligament like this. Now what we should do with that is, in a patient with, turn this way, yeah. Can you see she has a mid-sheet groove with malar mound, right? And on this side, you see how it completely mitigates that? Because you're just making this continuum of convex curve all the way around. Okay, good. We're going to stay with the voluma, right? Imagine like we're going to this like a proper patient who's coming to the office. It's still voluma day today. So we're now going to work with this area. Okay, so remember, vertical cavity, transverse cavity. So this is the mandibular retaining ligament. You want to leave the product just medial to the ligament. Can you see this recurring theme? Identification of cutaneous insertion of ligament, injection medial to the ligament, right? So get down to the bone and watch now. You see with the non-dominant finger, I will just rest it here just to make sure that I'm able to trap any product that wants to start to migrate down towards the jaw. 0.2 and that will do. Okay. When you're moulding this, 2 directions. One is medial, so you send it along the jaw, okay? And then the second one, this is very cool. You take your 2 index fingers, trap it in between your 2 index fingers like that. Just hold it just for a few seconds, and you'll feel it. You'll actually feel it just squish away underneath the pressure. And you know, the jowl is only jowly because of the relative depression of the prejowl sulcus next to it, right? So if you deal with this and connect the 2 together, straighten the jaw, you get this amazing clean and linear effect in the jawline. You see, whereas on this side, she has a very clear hill, valley, hill. Yeah? Okay, perfect. Stay with Voluma, thanks. I'm going to do, as we deal with this injection, I'm still going to stay with Voluma actually. So I go sub-DAO, but I don't go to the bone here because she's got mental foramen, hasn't she? So I don't want to have any kind of risk. So, and then I push that forwards like this. Now chin, apex, Pagonian, 2 different points. But we start with apex because that has an effect of both anterior and oblique extension, whereas the Pagonian only offers anterior projection. So maybe the apex will do both, one shot. So pick the midline like this. Find the junction between anterior and inferior border. 45 degrees straight down to the bone. Now watch this. I'm going to make her chin narrower straight away. See this? Now when it starts to become a bit elf-like, yeah? Don't go too beyond that point. And what you're going to do with that is you're just going to mould that now. So, and the objective of this is to make her longer, but also to make the chin narrower, so it's the same width as the nose, and also to try and give anterior projection. You all right? Now then, do you think that her chin width is now in better alignment with the nasal width? Yeah? Okay, perfect. Right, good. So that is Voluma is done. Now we're going to fix the tear trough by giving anterior projection to the SOOF and shortening the lid-cheek junction. I'll do this point. Corner of the mouth, labiomental crease. Okay. Look to the ceiling with your eyes. Thank you. Right. At that point, when I ballot the SOOF, you see how the tear trough improves slightly when I do this, okay? So this is it's really just about testing to see what the SOOF projection does for the infraorbital crease. Try not to go to the bone. Go through the skin. Now I feel the muscle now, and then I go into the SOOF. Not on the bone, and I'm just going to do a tiny little bolus between 0.05 and 0.1 cc. Now when you do that, you see that? That looks really quite a mess, doesn't it? If you did that with another product, there's no get out with this. But I'm going to now use this to mould medial and lateral so that I can actually have a double benefit from it. So take it and run it under the muscle ahead of your finger, like this, medially, and then take it and just run it lateral as well, like this.
Since we don't have bolt lip,
Yes.
but we have Bellaterra,
Yeah.
would you use that?
Yeah, of course, yeah. Which one, balance or?
Balance.
Balance, yeah. Here she has eye bag tear trough, okay, with the prominence of the malar mound and a sausage effect of medial malar compartment. Look now. Look up. That's it. So you see there, and then look on this side how she has that really beautiful correction here.
So this injection point was literally just at the lower
It's
end of
yeah.
the
Take
head,
the tear trough, yeah.
just as low as
At the bottom of the tear trough, just below the ligament, because if you're above it, you make the mound, the eye bag bigger. That's how you identify. Also, it is quite a tactile point as well. You
Yeah.
touch the SOOF. So while we're here in this periorbital area, why don't we just tackle this as well? So if we just go with, actually, is she squishy enough? Yeah, hold on. No, let's do Vollift, fine.
Yeah.
Yeah. Normally I'd use Volbella here, but unless we can use this. Like I said, 7 iron. Yeah. Do everything. Keep looking up. Sorry, don't it?
That's also in the bone.
But always on the bone, yeah. I think for all the infraorbital, you just stay on the bone. So what we should see now, I'll show you the lateral canthus here. I was talking there about injection canthopexy. It's pretty much what we're doing. But the oculoplasts hate this term, don't they? Okay, they want to beat me up. Okay, so look at the position of the lateral canthus here. You see? In fact, I would go so far as to say she has a positive tilt, right? Like the pencil, you know, when it goes up. Look at the untreated side. It has a downward vector like this. You see? With closure as well and volume loss. And then this is vertically elevated like that. Right, so we'll go with Volift now. Remember, the gun has the bullet, yeah? And we're going to put the gun against the skin, and the bullet is going to blast out of the opposite angle of the mandible right here, okay? That's your best angle to get away from the facial artery. So, if I pinch, you can see very clearly buccal maxillary retaining ligament is there, which means that the facial artery is running there, okay? And your safe injection point is there, okay? So God help the rookie injector who is injecting a nasolabial fold as his first task, yeah? This day is so dangerous. So we pull this back, pull the artery away, orientate the needle so we got the right trajectory, down to the bone, okay? 3 seconds of aspiration. And good to go. .3 max. Take the Volift and push it underneath the alar dome. What you're doing is you're squishing it on the piriform all the way medial, and you're forcing it against that little alar ligament. We should see nasal narrowing. Is it true? Yeah? Okay, good. And we should also see a little bit more of the cephalic rotation of the nose. Yeah, okay. So this is a very important point for this area. And the other thing is that, turn this way, you see, look, she has a sausage and a nasolabial depression, so alar fossa. Look at this beautiful transition that she gets now, you see, from a one-shot approach. Yeah, you don't need to be chasing that. And if you want to do the line filling in the sub-Q, that's fine. Just sandwich technique it. Yeah? Okay, look everybody. In the process of lifting, right, look how much elevation she's achieved in her left oral commissure. I've done those two. Let's pop this up. So remember, this is superficial. So this is sub-Q. And why don't I go deeper? Brilliant, well done, well done. So, when you're injecting this labiomental crease though, always make sure that you stay in that sub-Q level.
You mean immediately subdermal?
Yeah. The reason why you don't go intradermal is because actually you will get a prominence during smiling. It'll become slightly full. Okay, I'll show you something very cool now. By the way, the other thing is, you don't go deep here because you have gingival sulcus right there. You put it in the mouth otherwise. You've not got far, it's only thin, like 5 mil. All right, watch this. Show me a big kiss. See how she deforms and she's stable? Okay, relax. Show me the smile with the teeth, Kimmy. Look, fake and genuine smile. You see this, right? This is the myodynamics that I was talking about. You're giving people a result not just as a statue. Yeah, it's cool, isn't it? Yeah.
Really good.
You not just because they're not static. These are dynamic humans, right? So when she smiles now, then she has a glow about her. Good. Now if we're going to go for angle of mandible. So identify the inferior part of angle. Identify the posterior part of angle. Within a 1 centimeter square, you're going to go to the bone there. Okay. All the way down. And then you make the injection. Now you need to come out because you can't rotate the needle because you're going to bend it. Form that in first, okay, but form it by pulling laterally like this, okay? And then this injection here, you block it like this, okay? And get to the back end of the angle, like that. See, I'm on the posterior border of the angle of the mandible now, and I make that injection like this. Never inject here unless you're on the bone, because there's all sorts of stuff going on there. You've got parotid, you've got muscle, you've got arteries and all sorts of stuff. Now, what happens is, she gets this really nice silhouette effect here, yeah? And it makes the angle more beautiful. So ideally you want to see this at 94 to 100, like this. So on this side, see, she doesn't have it. She doesn't possess. You can make it really easily. It's just a little bit of sculpting. Look here. You want to go to the center, you want to optimize GK point, and you want to evert, okay, and also want to generate more height and anterior projection with the upper lip, okay? So those are the fundamental endpoints. So, transcutaneous approach, staying in this subcutaneous level. Well done, sweetheart. So all the way through. And then as I inject, I come back, and you'll start to see that the tissue actually facilitates the result, because the product is just in the right level. So what I do with this first one is just pinch it into place. Right, can you see what happened here? So she got a peak on the GK point, and also she became more everted in the upper lip. And you're not having to do a lot to generate all of those different outputs. Open the mouth. So that was for the Cupid's bow. There's another opportunity here to leave product here for the medial tubercle of the lip. Okay, well done. Sorry, darling. Look, I'm controlling my depth here. And then it rotates as I come out.
And you're injecting pretty much
As
the
I'm
entire
coming,
way.
yes, you're right, yeah. Because it's like a thread, I'm pulling it as I'm coming back. And then pinch this in, like that. And that's it, it's done, just a 2-point. If you want to do the philtrum, you can as well, just to define. But I won't do that, I think it's fine as it is, because she's got nice central depression already. So this is the Glogau-Klein point here. There is a corresponding point on the lower lip as well, okay, in the same vertical axis. It doesn't have a name, but lip beauty should have vertical symmetry. Here it goes. You see it, as I'm doing it. You see how it rotates outwards, yeah? Open more. Thank you. Good. Close. Gorgeous. So, I think one of the key features here is that we want to generate height and eversion rather than fullness and anterior projection. Those are the endpoints, really. So, up, and then we're just going to go all the way down to spine. Well done. Good, okay. So fix on the spine, and you should aspirate here as well, but like I said, it's less relevant. I've had blood here before, actually. It's not a big deal. And then, look, as you're there on the spine, try and restrict the flow of the product so that it's trapped between the two columellas. If it's trapped, what's going to happen is it's going to form a Christmas tree type of shape, like an Eiffel Tower. And the spike of the Eiffel Tower, or the star of the Christmas tree, will be pushing towards the nasal tip. And that's when we're going to get the most anterior projection. So maximum here is 0.3. Good. Sorry, sweetie. Now look what happens.
03, yeah?
Yeah, well, maybe 02. Turn this way. See, she has a much more open nasopiltral angle. Say now your name and address, darling.
Kim Thompson.
Do it again.
Kim Thompson.
She's still moving, but it's more stable now because that depressor septinazi muscle is mechanically blocked. She still needs the Botox there. Yeah, 3 units. And the Botox injection, by the way, is the same technique. So make sure that you're in the middle and you're between the two crura. Well done. Good. Keep your eyes closed. Keep your eyes closed. Now, there's 3 pops. There's 2 pops, sorry. One here is at the junction of the upper and lower lateral cartilage. You get through that. This is where the nasal valve is as well, so just take care and be nice and gentle. Then you're over the top now here of the upper lateral. And at this point here, there's a junction between the upper lateral and the nasal bone. So again, very gently over the top like this, okay? And then just get to the point. Look, so now here I am in glabella, all the way to the top. Okay. And then just feed your way down. So I need to inject here to not inject there and then into inject there, right?
Yeah.
You understand what I'm doing, everybody? Yeah? So I'm just filling the gaps, basically, yeah? And you can use this. See how it's very, very linear, yeah?
Mhm.
It's very stark. Don't worry about it, because with the Volift you can mold it beautifully. You just pat it down, okay, to make sure that it's lovely and soft. Otherwise it looks too fake. The other thing is radix point. You understand, yeah? So you get that as well. Radix point. Radix point is where is the highest point of light reflex in the nose. And in a female, it should be consistent with the upper base of the upper lashes. She has an excellent one. You see, if you look at her nose, see the radix point is the light stops at the level of her upper eyelash. Yeah. With people with a glabellar depression, they have a low radix. Okay. And people with nasal bone prominence, okay, they have a high radix. So you just modify it by doing this technique. So look what I did now. Come forward. Look, her radix is in the right position, okay? Look also now in the profile. She has a perfectly straight nose. Whereas before she had a hump and a hump and a dip, yeah? So in summary, we looked at total face approach, 17 sites, 2 different products. And so with temple injection, zygoma and maxilla, SOOF, infraorbital crease, alar base, oral commissure down to pregal sulcus, labiomental crease and into the chin, including angle of mandible, we managed to give brow lifting, also better contour in the cheek, a deletion of the tear trough and lateral lid cheek junction, much better transition from upper lip through to cheek, narrowing of the nostril, vertical elevation of the oral corner, so we have happiness and sadness side by side, straight jawline with no light reflex disturbance here in the lateral chin. So show me a big smile with the teeth, with much better elevation on the treated side, and now kiss for me. You see that she can deform on this side with jowl, and this side is stable. Relax, and then if I turn this way, she has a much better defined angle of the mandible, which conforms to that 94 to 100 degrees. And on this side, it's absent in the lateral part of the angle. So we'll just look at some more dynamics for a second. So if you could give me a big smile, please. You can see that the crow's feet is much less on this side than this side. Relax. And then if you, again, show me a big smile, that the sausage effect here is reduced on this side as well. Okay.